Okay, so we're about to get started. And thank you again for your patience, and Dr. Kibel is here. He's going to be the first speaker. But before we start, I'd like to just recognize a few people, who were involved in the preparation of this. So can you hear me? No? You can? Okay. So most important, as I said before, is what makes this possible is you, right? If there's no audience, then it doesn't matter if the speakers are here. We're just talking to ourselves. So I appreciate you coming. We have it being video recorded, and the video recording will be available online for people who were not able to make it tonight, or if you'd like to see it again. Usually it's available somewhere around the Halloween time. It takes about 4 to 6 weeks. And Joanne, who helped set this up and whose information you have, can direct you to that link once it's online at one of the Brigham websites. And the recording is being made possible, by a gentleman in a foundation, David Maris, who has really supported us, for almost 15 years to make these recordings available. Also, there's a gentleman named Bruce Brown, who's not here, but one of his colleagues are, from Dendreon, and they've helped to take care of the cost of the food in the back and some of the other things that related to the expenses here. Now, when you came in, you parked, and you had to push a button for the gate to go up, but we were told that when you leave, the gate will be up, so no one should have to pay for parking, and we will validate that, before you leave with administration downstairs. So I know it says you're supposed to take the ticket and go to the desk downstairs and have it whatever paid for, but the gate should be up when you leave because the parking should be included. Sorry, the gates are up? Perfect, thanks, Joanne. So in the back of the room, if you just turn for a minute, there's a bunch of people I want you to know and meet, because they're the reasons, why all of this happened. So first, the two people here on my left, Kelly and Joanne, really did the lion's share of the work, in terms of putting this together. So I'd like to give them a round of applause, please. Two people who are not here, but from the Brigham, Caitlin and Abby also, coordinated several of the efforts. I'm very appreciative to them, for doing so. And if you look one more time, on my right side, Shauna and Ashley, who are actually on my clinical team, also helped us out tonight in checking you in and getting things organized, making sure things go smoothly. I'd like to give them a hand, too. All right, so now we'll start with the program. I'll introduce Dr. Kibel, who's my friend and colleague. He's going to speak to us, come on up, Adam, from the urologic standpoint. He's the chief of urology, at the Brigham, several topics that he'll cover. The way we're going to run the program is we're going to go through the talks. Dr. Pomerantz will be next from medical oncology, and I'll finish. And then after that, there's going to be a question and answer period. The little pieces of paper that you have in your hand that you got on the way in and the pencil, use that to write down any questions that come up along the way as the talks are proceeding. So at the very end then, we can then sit down and go through the questions with you. After that, we have a reception just outside the doors you entered through, and there'll be plenty of opportunity there to talk as well. So I'm going to hand that microphone over to Adam. Thank you.
Thank you. I think the lapel works okay, right?
Yeah.
Does that work? You guys can hear me? Okay, perfect. Turn this off. Save the batteries. So those of you who've come to this talk before, I've included some of the same elements, but I've tried to vary it a... Oh, you can't? Okay, never mind. I used to need both mics. Okay, I'm double mic'd. Those of you who've come before, I tried to vary the talk a little bit this year, trying to hit on some of the questions that people seem to ask over and over again, maybe save some of those questions so that we can focus on a few of the others. So my job is to start with screening, and I'm going to get all the way through to surgical treatment. So PSA is a great test. Okay, I think it's really underappreciated how good it is. It was a test that was first linked to the risk of prostate cancer way back in the 1990s. Yes? The test became widely used in the 1990s. There are both positive and negative studies, which I could go through and highlight for you, but I think it's a waste of time. The bottom line is there are studies that have shown how useful PSA is, and there are studies that have shown how PSA is not very useful. Okay? So that's why it remains controversial. But at its essence, the key is that it's an imperfect test. It is elevated by things other than prostate cancer. And so PSA does correlate with the risk of prostate cancer. I think we all recognize that. Everyone you talk to who has any interest in prostate cancer does recognize that. The problem with it is that an elevated PSA does not equal prostate cancer, okay? And men with normal PSAs, a PSA of, I put it in heavy quotations, 1 or 2, still have prostate cancer at an appreciable rate. Also, PSA does correlate with the risk of aggressive cancer, which is ultimately what we want to find. We want to find the kind of cancer that's going to cause patients harm and not identify the cancer that is not going to cause harm, okay? And again, the problem is that an elevated PSA does not equal aggressive prostate cancer. I see patients, believe it or not, with PSAs 30, 40, 50, 60, okay, who don't have prostate cancer. At least it's not the kind of cancer that I can find anywhere. Now, that doesn't mean you should walk around with a PSA of 60 and not see a urologist, okay? But it does tell you that PSA does not correlate completely and perfectly with the risk of cancer. And patients with normal PSAs do have aggressive prostate cancer. You see patients all the time. They say, my PSA was only 1.5. How could I have bad cancer? Sorry, it doesn't work perfectly. This, I think, is the most interesting study. I try and throw up a couple of new studies. This is from 2016, but we don't really cite it that much. This is a study from a physician. He was at Dartmouth named Gilbert Welch. Now he's joined us at the Brigham. He works in the Center for Surgery and Public Health. And what he did is he looked at what happened when they initiated mammogram screening, and they looked at the initiation of PSA screening. And what you can see is a sharp decline in the risk of developing metastatic disease soon after PSA was introduced, and much better than mammography, okay? And this is not a percentage. People often say, oh, the percentage went down, because they used to be, there used to be 100 patients diagnosed with prostate cancer, of which, 100 had metastatic disease. Now we diagnose 1,000, and we still only have 100 metastatic disease. So you're diagnosing more cancers, but not identifying more aggressive cancers. No, this is number per 100,000. So this means in the United States population, we have decreased tremendously the number of patients who have metastatic disease, and roughly half the number of patients who die of disease. Now, this is an association. It's not causation, but it is very intriguing that it happened at the same time around PSA was introduced. Now, so we've introduced new biomarkers in order to try and do a better job of PSA screening. And this is what it looked like, back in 1990. Between screening and diagnosis, we had a great biomarker. It was called PSA. And between diagnosis and post-treatment, we had another great biomarker, PSA. Between post-local treatment and advanced disease, well, what we could do? We could follow your PSA. And lastly, as patients developed, unfortunately, metastatic disease, what did we follow? We followed their PSA. Now we have a whole host of other markers, okay? So this is some that you use between screening and diagnosis. There are ones between diagnosis and post-treatment. There are ones between post-treatment, you get a radical prostatectomy. Do you need additional therapy? There's a test called Decipher. And then there's even ones that Dr. Pomerantz might be talking about, which are useful when you go from advanced disease to metastatic disease. Part of the problem here is there are so many tests. This tells me, A, there's a huge need, right? It also tells me none of them work perfectly, okay? And I see way too many patients who come in who've had every one of these. We're going to talk about MRIs, plus an MRI. They all say something different. So at the end of the day, you kind of have to choose one and stick with it, because otherwise there's just too much noise and it's unintelligible. So the markers do two things. These are in the early stage disease, when you're screening patients. They're designed to either decrease the number of unnecessary biopsies. Many of the men in this room have had a biopsy. I guarantee you that none of them enjoyed it, okay? So if we can identify a way of preventing a biopsy, that's a good thing. And also improve our ability to identify the cancers that need to be found, the ones that are going to potentially cause patients harm. But even these are imperfect. So I just highlighted two of these. These are a few of them. The 5-score and 4K score are two that I like to use. They're in the serum. There are ones in the urine as well. You do an aggressive rectal exam. I put up two here, PCA3 and Select MDX. I'm not endorsing these. I'm just saying these are some of the more popular ones. This highlights both the strength and the weakness. I'm just putting up a few of these so you understand how they might work. So this is PCA3. This is a urine marker. You get a vigorous digital rectal exam. You pee in a cup. And what you can see is for different PSA strata, so 4, less than 4, 4 to 10, and greater than 10, the risk of having prostate cancer increases for a rising PCA3, okay? The higher the PCA3, the more likely you are to have cancer. Plus, The higher the PCA3, the more likely you are to have aggressive prostate cancer. That's what's in black. So if you have a PSA of over 10 and you have a PCA3 over 60, you not only have a 95% chance of having prostate cancer, you have almost an 80% chance of having Gleason pattern 7 and above. I mean, you're crazy not to get a biopsy if that's what it looks like. On the other end of the spectrum, though, you have a low PSA, low PCA3. Why would you, your risk of having prostate cancer, yeah, maybe 18%, 16%. Risk of aggressive prostate cancer, 4%. So again, this highlights one of the problems. There's no cut point in which I say, hey, you got no risk, right? The other way, this is the Phi score. Again, very useful test. The key thing is if you are willing to accept that 10% of patients could have prostate cancer that aren't detected, you could avoid biopsying those patients and then focus on the patients that have an elevated Phi score that actually can benefit from a biopsy. And that's actually 25% of patients. And that doesn't mean that those patients over time wouldn't progress to the elevated Phi score. It doesn't mean you're missing identifying a cancer that should be treated. It's entirely plausible, even likely, that a significant percentage of those patients would eventually, that had real cancer, would eventually be discovered. MRI is another tool that is increasingly being used. We use it on almost everybody now. I mean, the old style biopsy, you just stick, we call them systematic biopsies. I sometimes hear people call them random biopsies. The reason why we don't like random biopsies is nobody just randomly sticking a needle in there. I mean, we're trying to hit certain areas of the prostate. And you can see it here, the right side, the left side, middle, base, apex. And if you hit a cancer, that's pretty good. Or you don't hit a cancer, that's pretty good. But unfortunately, you just have to have the cancer be a little off and all of a sudden you missed it, right? And what about cancers that are higher, that are in the anterior part of the prostate? This is the rectum down here. We don't get up there with a needle biopsy core. So you could have a big cancer. I operated on a guy today that had a big cancer in the top part of his prostate. Didn't look like he really had cancer. We got the MRI and it was obvious, okay? So the idea became to start using MRIs in order to identify the cancer. Now, this is the way we do it. You got to make sure if you're going to go and get one from somewhere, you need to get a T2 weighted image, a diffusion weighted image, and a DCI image, and a 3T magnet. I don't expect all of you to remember that. Maybe go back to the website. But things like an open MRI doesn't work. You're just wasting money. I know nobody likes the claustrophobia of being in an MRI. Open MRIs don't work. You need a good scanner and a good magnet, okay? Otherwise, it's just not a useful test. Again, the same sort of story that you heard around the markers, okay? So as the score goes up, and this is a radiologist reading it and giving their impression. I want to emphasize their impression. It's not fact, it's an image. And they're looking at it and saying, this image looks to me like X, okay? But as the number goes up, the likelihood of having prostate cancer goes up, and the likelihood of having Gleason 7 cancer or worse goes up as well. So what we've decided as a field is if you have a 4 and a 5, that needs to have a needle stuck in it. Notice I didn't say it needs to be treated. You need to put a needle in it because you'd hate to remove someone's prostate that had a 5 and find out that there's like a 14% chance he wouldn't have cancer. That seems a little over-treatment. 3s, we usually don't biopsy 3s. If you're already biopsying someone as a 3, generally we'll stick a needle in it, but we don't biopsy those that frequently. And then 1s and 2s we leave alone. We just follow. So I think this has been a huge leap forward. And this just gives you an idea of what it looks like. Part of the reason I'm putting this up is to stop calls to my office about MRIs. So this is a nice, crisp T2 weighted image, and I'm showing you the cancer right there. That's not actually the important image. The important image is this one, okay? And this is the diffusion, the apparent diffusion coefficient. You understand why we call it something short, ADC? And that's the cancer right there. And I get calls from patients that say, I got my MRI. Now everybody can look at their own record and their own films. And I get calls and they say, I don't think they did the MRI right. It's all hazy. I can't see anything. Because what they really want is that nice crisp image. But this is the image that the radiologist can define the cancer. The other thing that happens is the patient's coming with a disc. And Anthony and Mark will vouch for this as well. And they want me to look at the MRI. There's like thousands of images on an MRI. I went to load one today. It was going to take 45 minutes for the computer to load the images. So we have a PACS system. This is a skill. This is a I can read, if there's a radiologist in the room, they'll be offended by this, but I can read a CT scan of the abdomen pretty well. This is tough. This is a real skill. And we need experts. Our radiology colleagues are so invaluable. So again, this is the other one, the DWI. Somebody looks at that and says, what the hell is that? Well, for a radiologist, that's cancer, okay? So this is sort of how our algorithm is. PSA, it's very important for the PSA to be repeated. I'm not talking about someone who's had a PSA of like 2, then the next year it's 3, then 4, then 5, then 6. We know what's going on there. But someone whose PSA is 2, 2, 2, 2, then it's 6, no, repeat it. It might have been something, it might have been a temporary blip, okay? And then you can do there are reasons just do a biopsy with an elevated PSA. I mean, I see a patient, his father has died of prostate cancer, and he's got an elevated PSA. It's going to be hard not to do a biopsy. We want to know what's going on, okay? Many patients we might observe. Patients say, look, my PSA is 4.5. I know I might have prostate cancer, but I just want to follow it. I don't know if I do that if my PSA was 15 or 20, but certainly when it's 4. Biomarkers are very useful in this space. And lastly, MRI. Treatment. So treatment, traditional surgery. I borrowed these slides from Steve Chang, one of my colleagues, very talented surgeon. I thought this one was particularly good. It's actually called an Omni retractor. Believe it or not, we use this kind of retractor for very big cases. But that hurts, right? And it is surgical trauma. I mean, all these different incisions we use. Anybody who's had an incision knows that it's not fun, and that adversely affects your quality of life. By that I mean it hurts. You got to recover. You got to take time off work, play. Hurts your golf game. It's bad. So what we're trying to do is do less and less invasive treatment. And Dr. D'Amico is going to talk about radiation therapy. I point out to people, we have a very good non-invasive treatment for prostate cancer that's been around for a long time, and that's radiation therapy. He's going to talk about it, not me. I'm not arguing against radiation therapy because I think it's wonderful and it's constantly being improved. But I'm going to focus on these surgical interventions. So laparoscopy, minimally invasive surgery. This is a figure from 2006 that shows the adoption. There's nothing up here about prostates because nobody did them. When I say nobody, that's not true. I did them laparoscopically, but there weren't enough to actually appear on this graph. This was cholecystectomy. That's where you move the gallbladder. This was nephrectomy for cancer all the way down here. And hopefully this will play. So the issue here is it's hard to do laparoscopic surgery. Your positioning is very awkward. You got to look down in the pelvis, but anywhere you're looking, it's hard to get there. And hopefully this will work. We're not going to play the whole thing. This is somebody tying a knot, okay, laparoscopically. And this guy is good. Like I'm watching this, and this guy is really good at what they're doing, okay? We're going to just let you guys watch it for a minute. That's not a prostate surgery. That's a gallbladder up here. And this is the liver, and he's tying off, the bile duct before they take out the gallbladder, okay? Let's go on to the next slide, see if I can do this successfully. So the Da Vinci came along, and everybody says, oh, you can do it with the Da Vinci. That's the only robot we have available right now for surgery like this. There are going to be more robots, particularly in orthopedics. There's a huge number of robots coming down the pike, okay? But at least for what we do right now, this is the only one. And this is me tying a knot robotically. I'm tying off the dorsal venous complex. This is actually prostate surgery. Here's the prostate here. Here's the pubic symphysis. That's the bone just beyond the penis, and that's the thread I'm tying, okay? And I don't think you need to be a surgeon to say, this looks a lot easier. You know what I mean? I even have a little trouble here, and I just recover right away. So anyway, a lot easier. And you can suture very well. I think the next thing you're going to see me before I advance this is you can actually see somebody suture. It's easy. Here's a needle. I'm going to pick it up. You know how hard this was really hard to do laparoscopically. And to do this takes a minute, less than a minute, 5 seconds. Okay? That's me just, I'm taking the urethra, the tube that you pee out of, and I'm holding it up in the air to provide a little more support that improves continence. So my point is, this is why the robot has taken over. We're a very busy robotic practice, but I try to tell people, We don't have a monopoly on robotic surgery. There are other places in the area that do a great job. They really do. I think we're good. I think others are good too. And the other thing I like to point out to people is good open surgery beats bad robotic surgery any day of the week. So there are a lot of good open surgeons out there that I know that do a great job. And at the end of the day, I do think the robot is better, but I do think there are some fabulous open surgeons out there who should continue to do open surgery, and it'd be a loss if they stopped. But it's not good enough. We need to get more minimally invasive. So we're exploring focal therapy, okay? So this is just an example of a 6-year-old guy who presented with a PSA of 6.2. The MRI showed one lesion only. Why do we have to remove his whole prostate? So he enrolled in a trial where we're doing focal therapy. I want to emphasize to everybody loves this idea. Conceptually, it makes so much sense. You kill the cancer, you don't remove the whole prostate. Again, Dr. Pomerantz and Dr. D'Amico will stand behind me in saying we have seen a lot of really reasonable things come along down the pike through the years, and they haven't worked. Do you think people liked radiation and radical prostatectomy in the 1950s? No, they didn't. And they're still the mainstay of treatment. A lot of stuff has come down the pike that hasn't worked, and what you need to do is need to test to see whether the concept actually works. So you hear a lot about people who hear about HIFU, and they hear about focal therapy, and what I tell them is there's no data out there. I won't say no data. There's no convincing, conclusive data that, in my opinion, that shows that it's good. But I got to tell you, I think it's going to be the future of our field because we just got to figure out how to find all the cancer. This is the same MRI that I showed you before. It's because it's the same patient. This is the gantry in the patient's rectum, delivering the ultrasound energy. It's high. Remember when you were a little kid and you took a magnifying glass and you focused on a leaf and you get it to burn? You can do the same thing with sound. Sound is a wave, so you can concentrate it and deliver energy inside someone. So that's delivering energy and killing that portion of the prostate, right where it was before. And this is what it looks like, a few months later, 6 months later after treatment. It's gone. That whole area is gone. And the patient's potent, he's dry, and on repeat biopsy, he has no cancer, okay? Now, I have other patients we've treated with this concept, and they have had cancer, like on repeat biopsy, okay? It did not eradicate the cancer. And we're doing this on Gleason pattern 7, not on 6, because 6 we're going to talk about 6 in a minute, and not on 8, 9, and 10, because 8, 9, and 10 is really, that's bad cancer. Good functional outcomes, potency incontinence, there are repeat cancers, okay? Lastly is active surveillance, and I'm going to be done. Active surveillance is for the lowest risk group, patients that have low PSAs. I should probably update this because I'll put patients on active surveillance now even with PSAs over 10, as long as they have Gleason 6 cancer and only a few cores that are positive, okay? Age, some people talk about age as not being a good criteria. I'll put young patients on active surveillance. I have a slightly different story with them. I tell them they're probably going to progress to treatment, but if we give them 4 or 5 years of better quality of life, I think that's a win. You have to be followed by somebody, and you have to repeat the biopsies. That's the most common question people say to me. Do I have to repeat the biopsies? I don't really want to come in that frequently. The problem with that is that's not active surveillance, that's inactive surveillance. And every patient that has gotten in trouble with me on active surveillance has been somebody who turns up in my office 2 years later, and they're like, "Hi, doc, how are you?" And I'm like, "Hi, well, how's it going? Tell me, how's your prostate cancer? Who's following it?" And they say, "You're following it." And I'm like, "No, I'm not. I have not seen you in 2 years." And that's not good. These are the results. I mean, it's hard to beat this. Prostate cancer specific survival, 98% of the patients at 10 years and 94% at 15 years hadn't died of prostate cancer. I mean, that's pretty good. Is that perfect? No. But the quality, you're trading quality of life for a little less, maybe a little less cure. Overall survival is good. A lot of these patients were older and died of other causes. So this is the question is whether patients, I see patients with Gleason pattern 7, and they say, "I want to be on active surveillance. Why can't I be on active surveillance?" And this is why. Lori Klotz went ahead and followed patients that had intermediate risk disease on active surveillance. He is the grandfather, father, uncle of active surveillance. He is wonderful. If any of you ever have a chance to hear him speak, he's great. And he really went out on a limb in advocating for active surveillance. And he went out on enough of a limb that he said, I'll put Gleason pattern 7 patients on active surveillance. He doesn't do it anymore because of this. So at the top, this is what's called Kaplan-Meier curves. What you're looking is over time, what is the changes in the patient population in terms of bad outcome. So at the very top, you can see the likelihood if you have low-risk disease, if you have a low PSA and a low Gleason score, of having bad cancer that progresses, or even a higher PSA is pretty good. It's around 94%. But if you have Gleason pattern 7, it goes down to 83%, and 4 plus 3, it's 63%. That means 47%, or not 40, 37% of the patients develop metastatic disease. That's not good, particularly in a disease that's curable. I mean, if I operate on those patients, or Dr. D'Amico gives radiation, the vast majority of those patients are cured. So I don't think that's a good option. So I'll wrap it up. Less aggressive treatments for low-risk disease in the right patient. Surgery improves survival. I didn't go through that, but in the right patient. Focal therapy is on the horizon. It's not arrived yet, but I'd say it's pretty close. Minimally invasive surgery, I think for everyone. But again, I stand by what I said at the beginning. If you have a good open surgeon beats a bad robotic surgeon any day of the week. And then I will turn this back over to Dr. D'Amico. As he's coming up here, I think we're rushed a little bit. Every year he says such nice, kind things about me. This is how I'm the new chief of urology. That was about 8 years ago. So I think I take that as a compliment that I finally aged out and that he's going to instead pick on Dr. Pomerantz for a change and tell stories about him and his youth.
Thanks, Adam. So a story about Dr. Kibel.
I asked for that, didn't I?
Actually, it is a lot, to become a chair of a department, especially one where you trained, 20, 30, 40, 50, 60. How many years ago, Adam, was it?
A long time ago.
All right. So Dr. Pomerantz is coming up next. And for many of you who have been here many years, you'll probably remember Phil Kantoff, who was here up until about 5 years ago. Now he's in New York, closer to his family, and works at Memorial Sloan Kettering. And Dr. Pomerantz actually is one of Dr. Kantoff's protege, but now a man who really stands in his own in terms of scientific discovery and clinical expertise. He's a medical oncologist in the Lang Center for Genitourinary Oncology at the Dana-Farber, and is going to be speaking to you about advanced prostate cancer, which essentially is different than what we had thought about before. I mean, we just came back from Chicago, this whole meeting on treating men with disease that spread to the bone in a limited way, with local treatments in addition to systemic treatments. Very interesting. It's a new world. So I'm interested to hear what Mark has to say about systemic management of advanced disease. And Mark, thank you for being here.
Okay. Thanks for having me. So it's nice to see a lot of friends this evening. So I'm going to focus, I just have a few slides, but I'm going to talk a bit about them. What's depicted here is the natural history of advanced prostate cancer, where a patient's PSA may begin to rise, perhaps after surgery or radiation, but has not yet metastasized. Over time, metastasis may develop, and if enough time goes by and the disease continues to progress, the disease becomes symptomatic. And it also can become, over time, resistant to our primary treatment, hormonal therapy. And the hormonal therapy is depicted here in the orange, androgen deprivation therapy, which is taking away testosterone. And as many of you know, that works for a long time. Prostate cancer is addicted to testosterone. Testosterone is fuel for its growth. And testosterone, the male hormone, when taken away from the patients, which we in the old days did by removing its main source, the testicles, and now do with medicines that achieve the same thing, the disease reliably goes into a remission. It so reliably goes into a remission that I kind of broke up this line. We can even treat intermittently. We can decrease the PSA, wait for it to rise to a certain level, and treat again, and reliably keep the disease under control. However, invariably, if a guy lives long enough, he will live to see the day when his disease evolves away around the hormonal therapy, when the disease is able to grow in the low testosterone state. And that's what castration-resistant prostate cancer is. This used to be a big problem because we didn't have many treatments for it years ago. And a lot of work has been done to figure out how to treat this resistant form of the disease. And now this picture takes us through 2018 of all of the FDA-approved agents, through 2018, all of the FDA-approved agents for this late stage of disease. And I'm leaving the idea of how late very vague and just writing time here because it varies dramatically from patient to patient how long this all takes. But we now have multiple FDA-approved agents, and I'm going to kind of sort them into groups, focus on 3 main types of treatment and what's going on in 2019. So the first is that to mention, and then we don't need to mention it, is chemotherapy. And since 2004, we've known that we've had chemotherapy drugs that when given to men with castration-resistant prostate cancer prolongs life and can improve quality of life, can really shrink disease down. Docetaxel or Taxotere, and then for patients that are resistant to docetaxel, there's cabazitaxel or Jevtana. And a third chemotherapy drug that was approved before all of these called mitoxantrone that is supposed to be in purple because the ones in blue are the ones that have shown to improve overall survival and the ones in purple just symptoms. And mitoxantrone, you probably can't see it from there, is in purple. It was approved just because it improves symptoms. But chemotherapy works in prostate cancer and is an important tool for us. One of the most important discoveries over the past 10, 15 years has been that even though the disease evolves a way to grow in the low testosterone state, it remains addicted to testosterone. It just figures out nefarious ways of getting it. So one trick that it may use is to overproduce copies of its receptor called the androgen receptor so that it has feelers out for any remnants, any bits of testosterone that may be floating around from other sources. The adrenal gland can make a little. Maybe the cancer itself evolves a way to feed itself, to make its own testosterone and feed itself. Or maybe that androgen receptor can start accepting other hormones that are floating around, even though testosterone is very low. Life is tenacious, and evolution ingenious. Sorry, I lost my ability to speak English. But it finds a way. And with that discovery, we were able to devise new ways of attacking that testosterone pathway. And many of you have heard of some of these drugs that have been FDA approved over the past few years, like abiraterone, which shuts down testosterone production at the cellular level, or enzalutamide and apalutamide, which block that androgen receptor, the receptor itself for testosterone. So this is an incredibly important class of medicines for advanced stage prostate cancer, and generally speaking, has less in the way of side effects compared to chemotherapy. Then I'm going to quickly go through the next. Radio-pharmaceuticals, these are molecules that are programmed to hone in on a specific kind of cell. The radiopharmaceutical that's FDA approved that has been shown to prolong life in prostate cancer patients is called radium-223. It homes in on bone, and when it gets to bone, it releases a little packet of radiation that's attached to the molecule to treat all disease that's in the skeleton. It's limited to disease that's in the skeleton, but it's very, very well tolerated, again, compared to chemotherapy. And then there are immunotherapies, using our own immune system to attack the cancer. I'm going to talk about these last three classes of medicines and talk a little bit about what's going on in these areas in 2019. So we'll start with the AR-targeted drugs. Apalutamide, that may be new to some of you, was just FDA approved last year and looks to be just as effective as the other ones that are that were previously on the market. It may be, and I don't know, none of these drugs have been compared head to head. No one with skin in the game has any incentive to compare these drugs head to head. But apalutamide seems to be fairly well tolerated in our experience over the past year prescribing it. And because each of these drugs are equally effective, the drug companies that funded the trials leading to FDA approval have searched for specific niches for their drug. And apalutamide was proven to be effective in trials for patients in this earlier space who are castration resistant but have no evidence of metastases. Enzalutamide was recently FDA approved for that earlier stage as well. But I'm going to focus on a brand new medicine that was just FDA approved within the past few weeks called darolutamide. And like the other utamides, like apalutamide and enzalutamide, it functions by directly attacking, in a very effective way, the androgen receptor. So even if there is a little bit of testosterone floating around, even if the cell has figured out a way to feed itself with making its own testosterone, this renders the testosterone useless because it attacks its receptor. And this was a large trial that was published earlier this year. Patients were randomized 2-to-1 to either receive darolutamide or placebo. And again, even though this medicine works just as well in men with metastatic disease, the company was looking for a niche, and when the study was launched, there weren't drugs approved in the non-metastatic setting, and that's where this drug was tested.
This is using PSA as the marker?
That's correct, yeah, that's correct. And with serial scans, as they watched patients over the course of months to years, they would get scans and were able to measure time to metastases. And so, and here is that graph. So this is, on the x-axis here are months. This is 36 months. And this graph shows time to metastasis, or metastasis-free survival. How long did patients survive before they formally developed metastases that could be seen on scan? And the darolutamide proved effective versus placebo. But what got a lot of our attention in the business wasn't simply that there's yet another AR-targeted drug, because we already had AR-targeted drugs. What seems to be special about darolutamide is, unlike its predecessors, it does not seem to cross the blood-brain barrier. It stays in the bloodstream as it courses through the vessels in the skull. And that could be a big deal for all of us, because one of the main side effects of enzalutamide is what can be a profound fatigue. And we've had many, many patients that either had to decrease their dose or drop the medicine altogether because the fatigue from the enzalutamide was so debilitating. Apalutamide in the phase 3 studies also had an appreciable amount of fatigue, though in anecdotally in practice, I think it may be a little bit less than enzalutamide. But darolutamide was associated with appreciably less fatigue. And unlike abiraterone, the other drug in this class, it does not need to be given with prednisone, which is another factor that influences our decision-making among these AR-targeted drugs. So we're very pleased that there is a drug that is effective in targeting the androgen receptor, but is very well tolerated. Okay, now we're going to talk about immunotherapy, which is always all over the news and has been one of the great achievements in modern oncology, using the immune system to attack the cancer. We know that most cancers can be effectively attacked, treated, contained by our own immune system. And one of the most important discoveries over the past 25 years has been the fact that the immune system has a braking system. A few scientists won the Nobel Prize last year for the discovery of the braking system and the ways that the braking system can be targeted. If you take the brakes away from the immune system and let the immune system go bananas, much of the time the immune system will consider cancer cells to be foreign invaders and attack them. Unfortunately, some cancers look more foreign to the immune system than others. So this form of immunotherapy, taking the brakes away, has been immensely successful in diseases like melanoma, kidney cancer, bladder cancer, lung cancer. And this type of immunotherapy has been FDA approved and changed the way we take care of those diseases. Prostate cancer has been a little trickier. I can talk about Provenge, the one FDA-approved immunotherapy, if you'd like, but I first want to focus on these more potent immunotherapies that affect the braking system. The first one that was studied in prostate cancer is called ipilimumab, which attacks a very particular part of the braking system and has been FDA approved for other diseases. And it has been tried in trials with prostate cancer patients. And as you can see from here, there are two curves, and the two curves look very, very similar. And those are curves of people receiving this immunotherapy or receiving placebo. It has not had much effect in prostate cancer. And this was disappointing when it was reported in 2017. But there are other, in some ways more potent inhibitors of the braking system. One of them is called pembrolizumab, and we've been using it in many clinical trials in combinations with other drugs. This is one abstract that was reported at our big conference, ASCO, this year, in 258 patients who received this for castration-resistant metastatic prostate cancer who no longer responded to chemotherapy. And the overall response rate was disappointing. But there were patients who did respond. And the subset of patients who did respond did have fairly long responses, especially for a prostate cancer in its latest stages. And there is a lot of work going on right now to figure out who those patients are and why they are responding and others are not. There is also a lot of work going on right now to figure out why the immune system doesn't seem to recognize prostate cancer cells as foreign. And is there anything that we can do to train the immune system to consider the prostate cancer cells foreign as we take the brakes off of the immune system generally. And so this is a very active area of research for our group. And then finally, I do want to mention radio-pharmaceuticals because there's a lot of activity in this area. As I mentioned, radium-223 is effective, but effective only for disease in the bones. There's a new drug that we have in clinical trials right now this is lutetium attached to an antibody that is not targeted at bone cells. It's actually targeted at PSMA, a flag that is on all prostate-related cells. And when the antibody hits its target, which is ostensibly all of the prostate cells, it releases this radioactive lutetium particle that should be lethal to the cell. This sort of smart bombing is very, very promising. We can make it even smarter because we can use this, I'm pointing at my screen as if you can see it, we can use this same flag as a way to image the cancer. So instead of sending a toxic particle to that flag, we can also send a signal that can light up on a scan. And so we have a study going on right now where we scan the patients, look for tumors to light up, proving that the marker is there, and then we send in the drug. And they've given this an awkward name called theranostics. So it kind of has therapy in it and diagnostics in it. So we're using the same principle to diagnose where the tumor is and to treat it. Again, this is very, very well tolerated. In the limited series that have been reported around the world, one in Germany, one in Australia, the response rates in late-stage disease have been pretty good, approaching 50%. And as we get better and better at this, we're hoping that we can see some long-term responses. This is an example of one patient. I don't know how well it's projecting, but this is a patient who had a PSMA scan, and as treatment went on, the disease was clearly shrinking.
Mark, just to clarify, PSMA is a PET scan.
Oh, right, yeah, that's right. Yeah, I'm sorry, the type of scan, I should have mentioned this because most of you have heard of PET scans. It is a type of PET scan. And so this is where we were in 2018, and these are the three areas that we are very focused on in improving outcomes for these patients. We're thankful that we really do have targets and real leads on how to keep the disease under control even at the latest stages. And I think I will stop there. Thank you.
That was outstanding. You know, it was a real pleasure to listen to Mark because I haven't heard Mark lecture in years, actually, because we haven't been together in the same space to have a conference like this. And I just have to say, Mark, you're really an outstanding teacher. Very clear. You speak English very well. Very clear, and I like the way you use the picture words. All right, so the last piece, and then we'll go on to our question and answer part, is going to be really a synopsis of different clinical trials. It'll highlight some of the things you've already heard, and it'll go, into, I use a single slide to basically highlight a whole series of trials on a particular area of prostate cancer, and I'll give you the punchlines and the interpretation. But I'll start with a story first, and this is one you should not have heard. So there's a couple And this couple has been together and married now for 40 years. And it's nighttime. They retire to the bedroom. And what's been going on now, really for the last 25 years, since the couple's wife, the woman in the couple's parents both passed away, is that just about 15, 20 minutes after they both fall asleep, she wakes up and she says to her husband, says, "Dear, I think I hear something downstairs. Would you mind going checking?" He says, "Okay, dear." He loves her dearly, and he knows that, this has been something that's been haunting her for a while. She was very close to mom and dad, and when they both left, this came up over and over again. So he goes downstairs. He spends a few minutes, walks down in the kitchen, living room. No one's there. He's done this many times. He comes back up. "I didn't see anybody there, dear. Oh, thank you so much for checking." He goes back to sleep. Half an hour later, wakes him up again, same thing. "Dear, I think I do hear something downstairs. Would you mind checking?" "Okay, dear." So he goes down one more time. And the second time he comes up and says, "I don't see anybody." That's usually enough, and they sleep the rest of the night. So this has been going on now for 2 decades, and he's gotten very used to it. So, it was a couple of months later, the same thing happened on that night, and he says, "Okay, dear, I'll go downstairs and check." And he's walking downstairs as he usually does, goes around the staircase, walks into the kitchen, and lo and behold, as soon as he walks around the corner, he's looking down the barrel of a gun facing right in between his eyes, and he's like shocked. Could this be for real? And so the man says to him, who's got a scarf over his head, he says, "Would you please put everything of value in this bag?" He says, "This is for real." He says, "Okay." So he does. And the guy packs everything up and is getting ready to run out the door, and he says, "Wait a minute." The burglar turns and looks and says, "Wait a minute." He says, "Yeah." He says, "Listen, can you do me a favor?" He says, "What do you mean? I just robbed you. What do you mean I'll do you a favor?" He says, "Can you come upstairs and say hello to my wife? She's been waiting for you for 25 years. Oh. Okay. So the first slide summarizes what Dr. Kibel talked about, the screening studies. I just want to come at it from a different direction to sort of put an appeal in for PSA. These are 3 plots, but what's important in these plots is 2 things. These 3 numbers, which I'll go through, and the fact that this plot, the lines are on top of each other. Here they separate after 12 years, and here they separate after 7 years. So these are the 3 big randomized screening studies in the world. The one all the way over on the left is from Europe. And in that study, what you found was that if you randomized men and said, "Get the PSA or don't," it turned out that after you figured out who got it, who was supposed to get it, and who didn't get it if they weren't supposed to get it, that there was not 100% difference. That is, either get it or not. There was about a 50% difference. Because what happens in these screening studies, as you can well imagine, is somebody says, "Well, I just got randomized not to get the PSA." And some people say, "Well, I don't like that idea. Some of my friends are getting it and they're finding cancer." So they go off and they go to a different doctor and they get a PSA. And so that takes this 100-0 and it cuts it down. So instead of everybody getting it or everybody not getting it, there was a 50% difference in this study. And even though it wasn't a 100% difference, there still was a separation. There still was less cancer death in the guys who got the PSA 7 years after they started being screened. It's a small difference, but it gets bigger with time. I want you to see this. See how these curves split more with time as you go out to 12, 14 years? And what I say to people all the time is that, if you are 50 years old, I think you're going to expect to live more than 12 to 14 years, I would hope. And so, at 50, 40, you might live 30 or 40 years. These curves could come way out and make a big difference. We don't have that information yet, but that's the strongest evidence for PSA. What's the weakest evidence is from our own country right here. Because in our own country, not any fault of the patients or the doctors who ran the study, people who got randomized to the arm don't get PSA all went and got it. The difference in the arms was 0. How can you possibly tell the difference whether PSA works when both sides of this trial are both getting it? And this was the data that the United States used in 2012 to get rid of PSA. This, a completely useless trial. So that's why the doctors were all annoyed 7 years ago, because this came out just after that, and they ignored this, and they paid attention to this. Now, 5 years after that, in 2017, this data was maturing, and they said, maybe we should change things a little bit. And so they went away from no PSA back to discuss PSA. And that's where we are today. And I would tell you in another 5 years, as these curves continue to split, we'll probably get back to consider PSA more strongly and in the right population. What about this one in the middle? This is an interesting study from the UK. Here, the difference in screen PSA or not wasn't 100%. It was 21% difference. Not much. But it's better than this, wasn't as good as this. And exactly what you'd expect to find is curves separated, not as quickly, later at 12 years, but nonetheless, they still separated. Because it separated so late, statistically, they couldn't show a significant difference. That's statistics, whereas they could show it here. But this completely aligns in my mind that if you now go over to the plot that we don't have, where this number is 100%, these curves should split earlier and bigger. And so in my mind, that's evidence that PSA works in the sense that it finds cancer. The other point Dr. Kibel made is what kind of cancer does it find? Does it find the kind that's lethal or not? Well, that's a whole other story. But I don't think that one should be declined finding prostate cancer lethal or not, because once you find it, then you can decide, do we need to treat this or not? But to say, I'm not even going to look because I don't want to find something I don't need to treat, I think that's a problem, because then you miss people who you do need to treat. This is another thing that Dr. Kibel mentioned. I'll just go through it briefly. There's a better biopsy now than ultrasound, this transrectal ultrasound guided biopsy. There's a much better biopsy. You get an MRI. The MRI says, those cloudy pictures says, oh, there's a cancer. And what you do is, instead of just going in and doing an organized approach to how do you biopsy the cancer, you take the MRI information that sees cancer clearly, or at least often sees it clearly, maybe 80% of the time, and you fuse it electronically onto the ultrasound picture. And then what you do is you say, okay, I've got an ultrasound instrument, but I have MRI information right on top of it. Put the needle into the area where the MRI shows the cancer. And this data, all these numbers here basically show you that it's better than if you do ultrasound alone. And these numbers at the bottom are the ones that tell you if you've got that score that Adam showed you, 1, 2, 3, 4, 5. So for the 3, 4, 5, the chance that you have prostate cancer for a 3 is 12%, for a 4 is 60%, and for a 5 is 83%. And those are the cancers that are clinically significant. They're not the kind you watch, they're the kind that you treat. And that was some of the best information that came out. And so if one is going to have a biopsy, they've talked about this over and over again, the best biopsy possible is preceded by an MRI, and then they actually target. Now, one more thing I want to say about this is I don't want you to walk away from this thinking it's perfect, because this is something I see with my guys a lot. So let's say the MRI finds a lesion that's right here. It circles around these numbers. And realistically, that box is going to be drawn to scale. It's what I'm going to show you now. The needle itself, when it goes through that box, does a sample like this, like this, like this. It samples the box where the MRI says, I see a cancer. It does not completely evaluate the whole box. So you can have an MRI-guided biopsy and come back and say you have no cancer, when in fact it's just because the cancer was there and the needle did this, or this, or this. So even an MRI-guided biopsy is not perfect. So that's why I tell people, who already have, let's say, a Gleason score of 7, but the MRI says score 5. We put a needle in the score 5 and it comes back and it says no cancer. Sometimes it's right and sometimes it isn't. It's an improvement, but it's not perfect. That's the point I want to make. Because people use MRI-guided biopsies to keep people on or take people off active surveillance. And I always tell people that You have more evidence now to stay on surveillance because the MRI-guided biopsy says it's just a 6. But the MRI-guided biopsy that says it's just a 6 is not perfect, and people need to hear that. The actual false negative rate, that is that there's really something more than a 6 and you just missed it because of sampling, is about 15%. Okay, now, this one you heard about before. I'll just spend 1 minute on it. This is an important randomized trial in which they took men in the UK and they said surgery or radiation and hormones or monitor with PSA. And the bottom line of that trial was either surgery or radiation, as Dr. Kibel alluded to, worked. You know, the cancer death rate at 10 years, whether you had surgery or radiation, was about 1 chance in 100. So it worked. Both treatments worked. But the difference was if you were monitored, the chance then of developing disease in the bones spread was about 6 chances in 100 versus 2 or 3 if you got radiation or surgery. And people say, it's 3% difference, big deal. But I want to invoke a concept here that you need to hear. That's at 10 years. And that sounds like a long time. You know, doctors say you wait 10 years and you run a trial. It's mature, let's report it. Yeah, well, that's true. There's a doubling of the metastatic rate from about 3 to 6% at 10 years if you were monitored as opposed to treated in this study. But when I look at a 50-year-old and he says to me, you know, I'm just going to monitor it because there's only a 3% difference at 10 years, I'd say, well, that's when you're 60. What about when you're 80? That number at 80 could be a lot bigger difference than the numbers at 10 years. So that's why it's important that a doctor sits and interprets this with you. Because the headline comes out and says, when this study was published, the headline came out and said you don't need to treat prostate cancer if it's, you know, in these favorable categories. And that's based on, you know, 10 years of information. So a 45 or a 50 or a 55-year-old reads that, or even a healthy 75-year-old reads that and says, I don't need to treat this. It's not true. It's only true if you're gambling and say, okay, well, in 10 years I'll go and jump out of a plane and kill myself, and then I'm all set. You know, I'm being a little facetious, but that's a lot of how medicine gets done, is that they say 10 years, that's very mature, because in most cancers, like the ones that, you know, Dr. Pomerantz mentioned, lung cancer, melanoma, bladder cancer, 10 years, the story is already told. If you're alive at 10 years after treatment of those cancers, you are in the free. But if the breast and prostate, that's not true. Those cancers can recur 20 years later. Or new cancers can occur in that organ 20 years later. Prostate and breast are very different. This is a radiation slide, which basically asks the question, what about doing the radiation in 4 weeks instead of 8 or 9? The so-called accelerated or hypofractionated approach. Lots of numbers, but what I'll tell you is that all of these studies met what's called the primary endpoint, showing that, in terms of how the study was designed, that a shorter course or a longer course produced the same recurrence risk, low and similar. And the issue, though, that I had with these, and the reason why I'm cautious in terms of how I use it, is that this is the key thing to see. This is how long the patients were followed, 5 or 6 years on average, right here. And we know from many, many decades of experience that the urethra and the bladder, particularly the bladder neck, the part that's closest to the prostate, are sensitive to radiation. And there's a small chance that you can get bleeding from the bladder from radiation, or the tube you urinate through the urethra can get tight or small. It's called a stricture from radiation. Those risks are 1 or 2 or 3% with radiation given over 8 or 9 weeks. But most of those events, those bleeding events, those stricture events, start happening 6, 7, 8, 9, 10 years after radiation is done. They don't happen at 1, 2, 3, 4, 5 years, rarely. The rectal events happen all within 2 or 3 years. The bladder and urethral events are late. So these studies convinced me that the recurrence risk is similar, but I don't know about the effects on the bladder and the urethra yet, given these follow-ups. One of the studies suggested that it might, in fact, be worse to get the shorter course of radiation. the p-value was pretty close to significant, and that was only after 5 years. What could it look like at 10? So when we refer someone for a short course of radiation who has the right kind of prostate cancer, the so-called intermediate risk Gleason 7, we make sure that they don't have any predisposition to developing a problem in the bladder or the urethra. That is, that they're not a person who's had to have one of those TURPs, where they take a little bit of the middle of the prostate out, or they laser out the middle of the prostate because they already obstructed at some point in the past. Or a man who's on anticoagulation, Coumadin or Lovenox, because they need that for their heart, because that kind of medicine can predispose someone to a higher risk of bleeding. So we're very selective in who we choose. Now this, I don't even know if Dr. Pomerantz or Dr. Kibel have seen this. This was just presented at ASTRO, our national meeting in Chicago, on Monday. And this is the first randomized trial asking the question, should one treat post-operatively after surgery if someone has a high-risk feature in a few months, even though the PSA is 0, or down the road, maybe years later, if and when the PSA ever becomes measurable, over 0.2 is what they were using at this time. And so this was the first study. It comes from Australia, New Zealand. It's a small study, as studies go. It only has 333 men. They wanted to get 470. The endpoint was whether or not the PSA rose or not. And the definition of PSA rise in this study was one we don't use anymore. The Mayo Clinic may still use it, but no one else in the country uses it, of a PSA of greater than 0.4. So I'm not going to go through all the math of the study. What I'm going to do, though, is I'm going to give you the punchline. The punchline is that people who got treated later had less of those things I just talked about, less bleeding from the bladder, less stricture, because they were completely healed. If they didn't get treated within a few months, got treated years later. That's what this says. And that's not arguable. That's significant by a large amount. What is arguable is this. What do these numbers mean? The people who got treated later didn't have a significantly increased risk of failing, of getting a PSA recurrence, but the way the study was designed, so-called non-inferiority, this number is important. This is what they were hoping this number would be or less, but it wasn't. It was a bigger number than what they were hoping. And so as a result, the way I interpret this is there are some men in whom doing the radiation within a few months after surgery, even though the PSA is undetectable, is beneficial, because some men might be at up to 75% increased risk of recurring if you don't. But who those men are, this study cannot tell you, because it's too small a study to break the groups up and see. But it's probably the men who have a number of factors that put them at risk, like a high Gleason score and a margin that's positive, and maybe invasion into the seminal vesicle. And that's how Adam and I and Mark practice already. If Adam's worried about somebody because he has a number of risk factors, he sends them, even though their PSA is undetectable. Now, just to hear, for those who want to hear this, on September 30th in Europe, at a conference called ESMO, the European Society of Medical Oncology, the conference that Mark's colleagues and Mark go to. They are going to present a meta-analysis of the 3 randomized studies that looked at this question. This one called Radicals from the United Kingdom, and one Jetug 17 from France. It'll have about 3,000, just under 3,000 men to try to see if they can answer this question or not, definitively. And that will have enough men to do subgroups in, to look at groups. But for right now, I think it's important to hear that the way we practice in Boston is that if you undergo surgery and you've got a lot of factors that concern the urologist, that this could come back, even though right now your PSA is 0, they send you to a radiation oncologist to have a discussion about treatment. And that, I think, is what this is alluding to, because of this very high number at this end here. Not definitive, but we'll have a little more information in a few weeks from the European conference. Dr. Pomerantz talked a lot about this, so I'm just going to summarize the main points. All these new directions that have come about as a result of these agents. He went through these in some detail, but the one I want to capitalize on one more time that he mentioned is darolutamide. Because darolutamide, just recently FDA approved, is very, very potent at blocking the ability of cancer cells to get the food, the testosterone they need to grow, but does not, because of its chemical structure, have the ability to get into the brain. When these drugs get into the brain and they affect testosterone impact on the brain, that's what makes people tired. That's where the fatigue comes from. This doesn't do that. So this is an exciting agent, I think, too, just like Dr. Pomerantz said, for future use. These agents here, darolutamide being one of them, apalutamide and enzalutamide, and I probably put these in the order of least to most in terms of side effects, in terms of lethargy and fatigue. Least, moderate, most. These have all been approved in this last year for men who don't have cancer that's spread to the bone, but have a PSA that's going up rather quickly, despite the testosterone being very low from Lupron, for example. And these agents have all been shown to significantly take the time it's going to take to get to the bone and make it much, much longer. And so those are all very important advances. And if, in my mind, and maybe at the panel we can talk about it, if I was going to choose one of these as the first choice, I'd probably use this one first, right? Because it doesn't, and especially in somebody who has any kind of CNS seizure disorder or anything, prior history of a stroke, something that's gone on in the brain, because it's gentle on the brain. These 4 agents, the chemotherapy at the bottom that Dr. Pomerantz talked about, and then these agents here, have all been shown to prolong survival in men where the cancer has gone into the bone. And Dr. Sweeney, one of our colleagues, just presented that at the national meeting this year and was just published in the New England Journal. Although that enzalutamide drug, as we mentioned, does, and he mentioned it honestly in the paper, does have this fatigue that we've talked about. Doesn't mean it shouldn't be used. It certainly should be thought about when other things are exhausted, but maybe not the first choice. Last topic. What about this? This is the whole thing that we spent 4 days in Chicago talking about. And I don't want you to think that this is a done deal, but there are 2 studies, both out of Europe, that suggest that if you have 1, 2, or 3 prostate cancer spread to the bone in 1, 2, or 3 areas in the bone, that treating the prostate itself with radiation may lengthen survival, lengthen the time that one has left. And that's what these numbers suggest. The reason why I say suggest and not prove is this thing here at the bottom, is that in order to say this with impunity, with complete certainty, when you ran this trial, you would have needed, before you started to enroll men and say, okay, you're going to get prostate treatment and you're not, that randomization, you needed to take the people and what's called stratify them into either in this group with 1, 2, or 3 Mets, or they're in this group with more than 4 or more. And that wasn't done in these studies. And as a result, these results here are suggestive and compelling, and enough to allow us to talk to men about it and sometimes offer it if they're willing, but not enough for me to say that it's definitely there. But here's what I do think, and it'll be interesting to hear what others think. There was a think tank on this in Hamburg, which I was at just about a month ago. And what I think is that if you take somebody who has metastasis in the bone and you biopsy one of those areas, and then you genotype it, what you do is you actually scan that biopsy and find all the genetic mutations. If you find a genetic mutation that's targetable, that one of those drugs that I had on these prior slide, any of these drugs, plus there's more than those. So you find a mutation that one of those drugs actually goes and targets. Then to me, at least maybe on a study, it would make a lot of sense if you're using a targeted agent in a person who has that kind of mutation in a bone metastasis to treat then the prostate. And maybe even to use radiation to treat the spots, the spot welds, so to speak, in various areas, because you've got a systemic treatment that should be effective. More so than just treating them all everyone who walks through the door this way because I'm not sure that we're benefiting them all. But we might be benefiting the group in which we can say this particular bone met will respond to this drug. Let's use that drug with standard treatment on top of it, and then add the additional local treatment. The surgeons, and Dr. Kibel knows this, is doing the same thing with prostatectomy in the setting of a study that these studies did. Last slide here is this new trial that's just opened last week at the Dana-Farber and at the Brigham. And it's one that our group is running. And it's really for men who have prostate cancer in whom it's been decided that radiation and 2 years or at least a year, 18 months, a long term of hormonal therapy, not 6 months, but a longer course has been recommended. And then what happens is that we follow the PSA closely. And after 6 to 8 months of the treatment, hormonal therapy has happened and the radiation is done, if the PSA has not become all the way down to less than 0.1, that they're eligible to go on a study where half of the men will continue that hormonal therapy that they're on, because that's the standard of care, and the other half will get that same hormonal therapy for the 1 or 2 years that they're supposed to get it for, but they'll get 2 additional agents, the ones you've heard us talk about, abiraterone and apalutamide, because we have learned that some men, not all, some, and that some number is somewhere around 25 to 30%, whose PSA doesn't come all the way down after 6 to 8 months of standard hormonal therapy, Lupron, Casodex, will go on down the road to have their PSA rise again, maybe years later. And by using these agents up front, way before that happens, perhaps you can make a difference and maybe it will never happen. So that's the new trial. It's basically taking things that would have been used in the future in some men and using them earlier in an attempt to not to have to use anything down the road at all. All right, so before I go to my very last slide, which is more of a philosophical slide, I have one more story to tell. This one you may have heard, but there are a lot of new people here who haven't heard this. This is one of my favorites. So this one is about a young man who comes to meet the parents of the young woman who he wants to marry. And so they introduce, and the young man goes and sits down with his future father-in-law. And they're sitting down and they're having a discussion back and forth. And so the first question out of the father's mouth is, well, tell me, what do you do? I'm so excited to meet you. And the young man says, well, I don't do anything right now. And he says, I'm not sure, what does that mean? He says, well, I'm a student. Oh, well, what are you studying? He says, well, I haven't really declared anything yet. I'm sort of just taking different classes here and there. He says, oh, he says, well, then, my daughter has been very used to, good things, and how are you going to be able to, make that come to be? And he says, I haven't really got a good answer for you, he says, but, I'll study hard, and I'm sure that somewhere down the road, that God will provide. And he says, okay. And he says, my daughter, also, and I heard that you are interested in having children one day. And, children are wonderful, as you know, but they cost money, schools and all the things that go in. How is that going to, come to be? And he says, well, as I said, I'm going to study hard, and I'm going to work hard, and I definitely make this, make this whole. But for right now, I don't have an answer, but I know that God will provide. So he finishes the conversation. He walks out. The young man and the daughter leave. And now the parents are sitting there talking with one another. And so his wife comes up and says, well, what do you think about him? And he says, he's a very nice man. He says, but I have one concern, in terms of our daughter, because he doesn't seem to, to have a plan in place or how he's going to, provide for our daughter. He says, but there is one thing about him that I have to say that I do really admire. And she says, well, what's that? And he says, well, he thinks that I'm God. All right. Okay, so I'll finish with this. And this is actually, more of a philosophical slide, but I've taken to doing this, at the end of talks, pretty much where I go, because I find that, this is the 20th year that we're doing this. And 20 years ago when we started this, not one of those drugs that we showed was known or used in this disease. There was no MRI-guided biopsy. The screening studies in PSA were just getting started 20 years ago. So much has changed for the better. And I know it will continue to change for the better until this disease becomes extinguished. And so knowledge that we just shared with you today is relevant but evolving. But this will never change. And so this is something I'll share with you. And you know, when I'm talking with students or residents or just young doctors just starting out, and they come to me and they say, I can't believe this just happened. This is terrible. And I said, well, what? And we listen to it. And what the first thing that comes out of my mouth, and many people here have been alive at least as long as I, maybe longer. You know this, right? This will be intuitive to you, but it's not to a 25-year-old. And that is that when something comes to you and it's not what you hoped for, you know that something is happening for a reason. And so my father taught me this at 16 years old when I came to him with some issue about a relationship. And you know, I had no idea at that time, you know, why. I was disappointed, et cetera, et cetera. And he said to me, you know, I want you to do this, son. I said, what, Dad? He said, I want you to keep a log. Just put today's date and write down what happened and how you feel. Just 2 sentences. And then 6 months from now, come back and answer this question. What happened next? And then talk to me. And you know, since I was 16, I have been doing this. And you know, there are books piled, you know, this high. Thousands of stories. Thousands. And not one of them has ever ended in a bad way. It always appears to be that whatever happened in that moment, I couldn't understand. But when you go 6 months, a year down the road, you look back and you realize if that hadn't have happened, I would not have gotten to where I am right now. It had to happen to steer me on to a different course so I could be just where I am. And that has allowed me personally to get less anxious and worried when something difficult happens, knowing that there's a reason this is happening. I have no idea what it is, but I will find out with time. And to me, that's the basis for hope. And so what I say to you, you know, is prostate cancer treatment has evolved amazingly in 2 decades, amazingly. There was really nothing. I mean, when I started treating prostate cancer, radiation was so archaic, that we used to hand people a pink bucket when they went in the room and on the way out, because they would throw up within, you know, a half an hour. That's when I was a resident after being treated. Because back then we treated with a radiation field, one from the front, one from the back, and there was no blocks, nothing. The bladder, the rectum, everything was completely treated, the small intestines. It was terrible. These poor men, you know, they'd come out and they'd throw up, you know, right after every treatment, if you can imagine that. In surgery, Dr. Kibel will tell you, not much better. You know, I mean, they used to call it a bloodbath, right? You used to go in and the whole pelvis would just fill up with blood. I don't know how they operated in that kind of situation. None of that's the case anymore, none of it. And, you know, the systemic treatments, the medical treatments, it's amazing. So what I'm telling you is, you know, a lot of people who came before us, who were treated in that era, who may still be with us, but not functioning like men today who function, who are treated in this era. Even though it's terrible to get the disease, the quality of life has improved dramatically. The cure rates have improved dramatically. And I'm sure 20 years from now, I may not be standing here, but I don't know if this disease will exist anymore because of the pace and the rate at which things have improved. And to me, that's the basis for hope. So thanks for your attention. Yeah. So what we're going to do is we're going to have you get your questions ready, and Joanne and Kelly are going to come around and collect them, bring them on up here, and I'm going to get a third chair. Okay, and then we'll sit down and we'll go through all of these for you.
While you're looking through them?
Yeah, we need the mic.
This question says, why not keep testosterone levels low after surgery? I think that depends an awful lot on the actual disease you're talking about treating. I mean, if you have somebody who has low-risk disease, by that I mean Gleason 7 cancer or even 6, because we do operate on them, well, why would I ever provide castration in that group of patients. There's actually data out there that would say those patients won't live as long if they get castrated than if they don't. And that's in part because testosterone ablation or hormone ablation is well tolerated, but it does have some side effects. When you give it to somebody for 5, 10, 15 years, it can cause some debilitation. I mean, around bone strength, muscle strength, maybe even some cognitive loss. There's some data that Dr. D'Amico can, which is controversial, that he can comment on that's around heart health. So we only want to put patients on that if they're actually going to benefit from it. I talked about PSA. A PSA is a wonderful test, and we can follow even the patients that have high-risk disease and see if the PSA comes back and if they actually have metastatic disease and would benefit from it. And so there's no real reason to keep testosterone low after surgery for routine care. Now, we are doing some trials where we're trying to look at very aggressive hormonal therapy for a short period of time after surgery or before surgery, and that's a different story. I mean, that's a short treatment, not lifelong, in patients who are highly likely to develop metastatic disease and who are only going to give it to for a set amount of time. So why don't I'll look over these other surgery ones and let Mark tackle one.
Okay, there were a couple of questions here about this new medicine, darolutamide, and I really like this one question because I've been thinking the same thing. This question is, why not use darolutamide as the first-line treatment? Certainly instead of abiraterone for castration-resistant disease, or I could even take it a step further. What about using darolutamide, which has such a great side effect profile that keeps testosterone intact? What if we just use that as our first-line hormonal therapy? I think that this is an important question and one that we're going to be addressing and answering, and anecdotally finding out more and more about. Androgen deprivation therapy, or just taking away the testosterone the old-fashioned way with a drug like Lupron, has side effects. It affects men's muscle to fat ratio. It affects mental sharpness. It causes hot flashes. It can affect mood. And if we keep the testosterone intact with a drug that targets the androgen receptor rather than takes away testosterone, especially one that doesn't go into the brain, maybe we can offset a lot of the most feared side effects of hormonal therapy. I think we will be looking at a medicine like darolutamide, or darolutamide itself, as the first-line treatment in the coming years. I think it's a very insightful question. A couple of patients asked about that, and darolutamide did show an improvement, it was FDA approved because it showed a delay in metastasis-free survival. Someone asked, what about overall survival? Yes, it did improve overall survival compared to placebo. It also, and the question about, someone asked a question about did it improve quality of life? It was only compared to placebo, so it wasn't directly compared to the other medicines in terms of quality of life.
So there are a number of questions about, are there health-related activities, diet that one should consider after primary treatment for prostate cancer, be radiation, surgery, and is there any evidence for it? So all of the level 1 randomized trial evidence about dietary interventions like vitamin E and selenium have not proven to reduce the risk of prostate cancer up front or recurrence. However, there is what we call level 2 evidence from large population studies that something like soy in the diet, which is like an estrogen, which comes mostly from the Asian population, which prior to being inhabited by US diet like McDonald's and Burger King, had very low incidences of prostate cancer. So soy is something that I can't say is absolutely going to reduce risk of recurrence or absolutely going to reduce the incidence of prostate cancer, but certainly can't hurt. Along with that is green tea, and then the other thing is something called lycopene, which is what's in cooked tomatoes. In terms of exercise and just reducing stress, that's an excellent idea for any number of things. It's been proven to improve cardiovascular health, Whether it actually reduces the risk of cancer recurrence is not known. However, one thing that has been shown quite convincingly is that people who are in a happy relationship, whether it be marriage or whatever, are more likely to live longer irrespective of what treatment they got with prostate cancer. My colleague Paul Nguyen actually was the primary author on that study. And again, it was observational. It's not a randomized trial of randomize people to a happy marriage or a bad marriage and see what happens, but rather it was just looking back and seeing is there a good relationship or not. And we think that it might be good relationships, foster people's health and make them more likely to comply and to want to be treated as opposed to not. And there's one more thing, and I'll hand it over to Adam. Could brachytherapy or seed therapy be used in basically men with low-risk prostate cancer? So men with low-risk prostate cancer, Gleason 6, low PSA, are people who some of them are candidates for what we call surveillance, but certainly you can use monotherapies, be it seeds, external beam, or surgery in those groups as well. And that's what that PROTECT study was about. In terms of brachytherapy, there's one more criteria, and that is that the prostate has to be small enough and the urinary symptoms have to be less enough so that you don't get a problem putting the seeds in all the right places and you don't accentuate a person's urinary symptoms. So prostate size is generally under what's called 60 cc's, and a person who's not getting up more than usually twice a night, not urinating more than every 3 hours during the day, and has low-risk disease could be someone in whom you would use, there you go, seed therapy if they were not interested in surveillance.
I want to comment. I love that marriage study. I quote it all the time, people. My wife likes to point out that, that I'm lucky to be married to her for a number of different ways, including this one. I like to point out to her there are a lot of unmarried men in the world, and maybe maybe it's an association, not causation, but that's the kind of debate that I have with my wife. So I have two questions here that basically are focused on focal therapy and HIFU. The key element about both these treatments is they've been predominantly tested in men that have Gleason 6 prostate cancer. And at 5 years, the reports say there's no, the patients do well. And there's no evidence of cancer without doing any biopsies or anything, just saying the patients are doing well. And I think if there's one thing to take home that maybe we didn't say explicitly is if you have low volume Gleason 6 cancer and we feed you corn, you're going to do great. Okay? So that is the problem with how the studies were done in the past. Proof of that is the fact that these therapies, both focal therapy and whole gland HIFU, are FDA approved for the ablation of prostate tissue. Notice, that is a very different statement than it's for the treatment of prostate cancer. And they do not make claims to anybody that they treat prostate cancer. And the reason for that is because they've never been able to prove that they treat prostate cancer. Now, in 2019, there are a number of different companies that have realized that this is an issue, and they're going ahead and doing the right trials where they're studying this treatment in patients that have Gleason pattern 7 disease and trying to demonstrate that they actually improve meaningful outcomes. Repeat biopsies where there's no cancer. Patients have improved survival. Part of the problem is that still the cancers that we're treating, the patients it takes 10 years for it to have an impact on their outcome. Companies don't have that much time. Company doesn't produce a product, they're out of business in 10 years. And so that's probably a little bit of a failure of our capitalist system and how it treats diseases that are a lot more chronic than prostate cancer. So to answer your question, focal therapy, is it close? That's certainly not months. We're talking years. I mean, the company that I've been very involved with in Cytec, that was the study I showed you. They're going before the FDA to get the FDA. The way it works is the company goes before the FDA, says, we want to get approval for this. And then the FDA approves the trial where they prove that it actually will be demonstrating that it actually works. And they have enough data to go before the FDA to design a trial that proves that it actually works. So that doesn't mean, that's going to take time to run the trial. The same with whole gland HIFU. I mean, I hear advertisements for this. It is FDA approved, but insurance companies won't pay for it. I mean, people go to Bermuda and they go to Canada in many cases in order to get it treated. Often they have to pay for it out of pocket. There is a move where people can actually get, some people to pay for it, some companies, insurance companies. I think it's safe in the right person, but I don't really see how it provides benefit. We've been focused mostly on the focal ablation as opposed to the whole gland ablation. Side effects of whole gland ablation are pretty significant.
Okay, I got a couple of questions about a very important question about disparities in prostate cancer incidence and natural history. Men of West African ancestry are at higher risk of prostate cancer than any group that's ever been measured in the world. We don't know exactly why, but we've learned a lot over the past 20 years. We know that part of it are have social causes and are part of some of the shameful traditions in this country. We know that in the heat of the PSA screening era in the 90s and 2000s, African American men were inadequately screened. We know that African American men, when diagnosed with prostate cancer, are offered definitive treatment less often than men of European ancestry. On the other hand, in addition to that, there do seem to be some differences in the biology of the disease in some African American men, or I should say men of West African ancestry. There are genetic variants that one inherits from their mother or their father that seem to cause prostate cancer, or put African American men at higher prostate cancer risk than men of other ancestries. And we know in the one study of active surveillance that was done that included African American men diagnosed with low-grade disease did seem to do more poorly with active surveillance than the studies that we presented here today that were comprised mostly of men of European ancestry. We don't know exactly why there may be biological differences. It seems that Gleason score for Gleason score outcomes are the same, but men of West African ancestry seem to be diagnosed with more aggressive disease more often. Our lab has one hypothesis we're working on with some colleagues at Baylor University. And there are some scientific hypotheses floating around of some of the differences in prostate cancer biology across ancestral groups. But just to get on a soapbox for just a second, this is where I believe that some of the latest trends in PSA screening, trends that Dr. D'Amico touched on in his talk, have particularly hurt men of West African ancestry. We know that PSA screening rates have fallen off in the wake of some of the trials that Dr. D'Amico showed, and I think that affected African American men disproportionately. African American men absolutely need to be PSA screened starting in their 40s, and much of the trend in PSA screening has not addressed that fact. Primary care doctors were educated over the past 5 years or so that PSA screening may not help people in general, but but my feeling is that it's absolutely necessary in men who are at higher risk of prostate cancer, and that's not just men of West African ancestry, it's also men with a family history of the disease. They're also in their own special category. That was a rant more than an answer.
Well, I'll pick up on that because somebody asked, how can primary care physicians be re-educated about the PSA data? So the way primary care physicians, for the most part, take their education is in CME courses. So for example, one of the largest CME courses for primary care physicians is held in Boston every year in Cambridge at the Royal Sonesta. And the talk I give there is just on prostate, and a big part of it is PSA. And there's about 1,000 primary cares that come there every year. I just chatted with them, just a couple of months ago about everything you heard in even more detail for them. And it's amazing, that of all the questions that primary care physicians ask about prostate cancer, that's the number one thing. It's all about PSA. Very little bit about treatment, because once their decision is, do you get a PSA or not? PSA's up, they send them for a biopsy, then the urologist takes it from there. So they just really want the PSA question answered. So education is one thing. The next thing is their societies. There's this American Academy of Family Practitioners, the AAFP, there's American Medical Association. There's these societies that they belong to. And there are consensus statements that they adhere to within those societies. So being on expert panels, I'm on one of them, I'm sure Dr. Kibel and Dr. Pomerantz have probably been on these, if not already are, to talk about the utility of PSA on consensus panels that then get put into guidelines. We all have these in our various societies, but having that made apparent to the primary cares. But I think that the other thing too is that, one thing in addition to high-risk men is who else is at high risk are men who have had prostate cancer, their sons and their brothers. Not necessarily their grandchildren or their nephews, because that's not quite first degree, but it's definitely the sons and their brothers. Need to at least hear, if you think that it's appropriate for you to speak to them about the fact that if you've had prostate cancer, that their risk, the population risk in the United States is 1 in 6 lifetime risk. A first-degree relative is 1 in 3. And to me, 1 in 3 chance of getting a cancer is a pretty high risk. So it's something else for to hear. The other thing I'll just address is side effects. People are asking cardiac complications with hormonal therapy and hot flashes. So cardiac complications, there's no question from randomized trials in radiation and hormones, the one from Spain, the DART 0105, I didn't present it, that the more hormonal therapy you give, the more at risk you are for non-fatal cardiac events like heart attack, pulmonary embolus, and congestive heart failure. The absolute incidence of that, the chance of it happening is a couple of %, but the risk enhancement is twofold. So said another way, if your risk of having a heart attack was 1 chance in 50, after hormonal therapy, it's 1 chance in 25. So just to give you, an idea of that. And then in terms of fatal deaths, that is yet to be determined. That really is probably going to be just sequestered to people who've had prior heart attacks or strokes or other events where a clot was involved. And anybody who comes through our door who has any of those events, before we put them on hormonal therapy, we either have a conversation with their cardiologist about the utility of a more recent stress test, if one hasn't happened in that past year, just to make sure that the cardiac health is up to date. Yes?
People are asking about Alzheimer's disease.
Oh, that's a good, so they didn't put it here, but what about Alzheimer's disease? Because that data came out of the University of Pennsylvania and has not yet been validated in other large databases, but let's be clear in terms of what it really said. So it said for people who got at least a year of hormonal therapy that there was an increased risk of being diagnosed with Alzheimer's disease at some point down the road. Now, the Penn group is very good. I came from there, and they have very good statistics. So the statistics in the study is not a problem. It's rigorous. The problem is that it's what's called a cross-sectional or observational study. So it's not that every man in the United States who's had prostate cancer was then followed and all the information was available to see what happened. So let me give you a very specific example. What they didn't have in that database, for example, was somebody, if they had a family history, let's say, of Alzheimer's disease. What else they didn't have in that database was whether the person was on medications that might be used to treat memory issues of other types besides Alzheimer's disease. And Alzheimer's disease and prostate cancer affect men in the same age group. So if you take two things that are relatively common and you try to see if there's an association without adjusting for the predisposition to get Alzheimer's disease completely, which you can't do in an observational database, you can get false associations. What do we know for sure about neurocognitive issues with hormonal therapy? For sure, the United Kingdom group showed us that if you're on hormonal therapy for at least 12 months, your ability to perform higher mathematical functions, I often tell my guys multiplying two-digit numbers in your head, 24 times 36, is still possible if you were able to do it before, but it's slower. So doing more complex mathematical techniques becomes slowed after a year of hormonal therapy. That's been shown rigorously in prospective studies. But nothing to do with memory, and nothing to do with Alzheimer's disease where you slowly, progressively decline, and eventually die of the disease. That has not been shown definitively. So I want to make that really clear. And the other thing, too, is once you come off the hormonal therapy, that neurocognitive issue about higher mathematical function dissipates as testosterone returns.
Yeah, before I answer this question, I want to comment also a little bit about the PSA screening and what we're doing to try, because we are doing very concrete things to try and improve that, particularly around our internal medicine colleagues. So the reason why we got this to this point was we were over-treating and over-diagnosing prostate cancer. There's absolutely no question about that. And so there was pushback, and eventually we reached this point where we said, okay, what you're going to have is shared decision-making, and that's where we are right now. And the problem with shared decision-making is if you ask an internal medicine doctor what he's supposed to do in a 10-minute visit, and probably Mark's the closest person in this room to that. He board in internal medicine? Yeah. My God, it's a lot. I mean, I'm not kidding. It's like the book is like this thick. I once looked it up. I mean, everything from, hypertension, how's your family doing? Are you having suicidal thoughts? It's a huge litany of things. And what happens is they're overwhelmed. So what we're trying to do is leverage the electronic medical record to do a better job of that. So a patient comes in and they're supposed to be considered screened for prostate cancer because they're in the right age group, and people don't like hearing that we're not supposed to be screening people over 75. I'm not going to get into, it's a complex subject, but the bottom line is people in their 80s are getting screened, and it'll pop up if you try and the physician tries to order a PSA in the wrong age group. Do you really want to order this? They can order it, they just have to defend it. And if they try and they don't order one in an appropriate patient who hasn't had a PSA in 3 years, say for instance, had a PSA of 1, hasn't had a PSA in 2 to 3 years, the thing will pop up, I think it's called the BPA, and say, you haven't ordered a PSA in 2 to 3 years, shouldn't you consider doing it? And the physician has to answer that. And the idea behind that is just like taking multiple choice tests, you learn from answering the same question over and over again, the physicians will be guided towards what is guideline appropriate care. So that's something that we're doing. Mike Healy, who's the Chief Information Officer for the Brigham, and I are doing it with collaborators at Memorial Sloan Kettering. And our hope is that we'll at least see more appropriate screening. So higher screening rates in people at higher risk, lower screening rates in people at lower risk. So the last question I have is about open surgery. It says there's a surgeon in Vancouver, British Columbia, who does open surgery and preserves both nerves and bundles every time. Has anyone from the Dana-Farber gone to see this procedure? So there's two surgeons that I can think of that are in Vancouver that are very good. One, his name is Martin Gleave, who does do open surgery. I think he also does some robotic. And Larry Goldenberg, hopefully I'm getting that name right, who does just robotic surgery now. Both are fantastic. Both are wonderful. Neither spares the nerve every time because that wouldn't be a good idea. And the reason for that is there are plenty of patients out there that we should not be preserving the nerves in. Patients that have cancer that is very high grade, that's on the side, on one side, possibly even invading outside the prostate, you want to achieve a negative margin. People who spare the nerve every time are generally treating patients who have Gleason pattern 6, which is the kind of cancer that doesn't need to be treated. So I talk to these people all the time. I see them regularly. Martin Gleave was the visiting professor here the first year I was here. Believe me, we seek out other people's knowledge constantly, not only in urology, but in all three of us, because we don't have a monopoly on truth. Well, part of the reason I'm here, not here, but here, is I want to do a better job. I want to put myself out of business, and the best way to do that is to tap the knowledge base of other people who are, if not as brighter than I am.
It's a nice segue to passing the microphone to me. Someone asked about genetic testing and how it could influence therapy. And it's a very important question because it is something that we're thinking a lot about. Now that sequencing the human genome is very tractable, there have been a number of important studies that our group has been a part of sequencing metastatic tumors from prostate cancer patients. And we've learned some very, very interesting lessons. One lesson that we learned is that a little over 20% of advanced prostate tumors have mutations in what's called the DNA damage repair pathway. It's a pathway that makes it difficult for the cell to repair its own fragile DNA. And we have drugs that can take advantage of that. Drugs that are used in ovarian and breast cancer, where that mutation is seen commonly. So we now have many studies open currently where we genetically test our patients, and if they have a mutation in this pathway, we have drugs that specifically address that. We're also learning that more prostate cancer patients than we realized harbor mutations in this pathway. These are mutations that are famous for causing breast and ovarian cancer, and they occur more commonly in prostate cancer patients than we previously appreciated, and we will be testing for that, and I can talk about that when we have more time. We also know that there are mutations that appear to make tumors more vulnerable to immunotherapy, which is another reason why we're doing genetic testing. And some other drugs, someone asked about CDK7 inhibitors. There are mutations that lend themselves to that as well. So genetic testing will increasingly be part of what we do when we're making decisions about treatments in the late stages of disease. We do have to ask something of our patients. Because these tumors evolve, we do need to see an updated genome, which does require a biopsy of a metastasis, which sometimes is a bit of a chore, but it is important, especially in the latest stages of the disease.
So I'll finish off, and then we'll, exit, and there's food right out, behind the central doors. Please help yourself. There's some healthy food just across the way. There's less healthy food if you make a right-hand turn. So you can choose. But I'm gonna finish with one question. I want to just capitalize on something Mark just said. I alluded to it as well. This genomic testing. So the genomic testing of the tissue itself, the prostate cancer itself, if you test the prostate, may not be the same genomics that are in a bone prostate cancer where it's spread to. Because as Mark said, it evolves. It can change with time. It can get more aggressive. So if you really were thinking, I want to cure this disease, you have to be able to identify the area in the body where the prostate cancer contains the most aggressive, worst aspect of itself. And logic would tell you that it's probably in the area where it has spread to as opposed to where it started. That's logic, although we'll have to prove whether that's true or not, because you'd expect the cells that got out and were able to spread would be more aggressive. That's our assumption. Whether that's true or not, time will tell. But targeted therapy is amazing. I'll just share a quick story with you on this. Not in prostate, but in a different cancer. I have a friend who had developed pancreatic cancer a year ago. And there's chemo, and there's radiation, and there's surgery that you go through for this. And it ends up with surgery at the end, which is this thing called a Whipple, where they take out most of your pancreas, part of the small bowel, a piece of the liver, and you get completely replumbed on the inside. Well, this person happened to have a BRCA2 mutation. It's one of these, it's 5% of pancreatic cancer. It's very rare. But it happens to be one of these DNA repair, mutations that's very prevalent in breast, ovarian, and also somewhat in pancreatic. She went through this chemotherapy, which include a oxaliplatinum agent, which is very, very toxic to BRCA2 mutational containing tissue. She went to the surgery. There was not a single cancer cell found. Now, for pancreatic cancer, that's almost unheard of until genetically targeted treatments. And I think that we'll see that I think we already are seeing that in prostate as well to some extent. So that's a futuristic piece. That coupled with immunotherapy provides, in my mind, a lot of hope for the future. Last question that I have here. People were when Dr. Kibel talked about the MRI and the quality of it, he threw something up there on the screen at the bottom that said 3T. So if the magnet is 3T, 3 Tesla, it's a measurement of magnetic field strength. If it's a 3T, at least here and probably most centers, you no longer need to have a probe put in the rectum if it's truly 3T. If it's 1.5T, half that magnetic strength, then a coil goes in the rectum to get the quality of pictures that you'd get with a 3T without the coil. So, and in terms of, the claustrophobia and so forth, if people are claustrophobic, the last thing I'll say to you is just ask the person who's ordering the MRI if you can also get a prescription for Ativan, which is just an anxiolytic. It gets rid of anxiety. Someone has to drive you to and from the appointment. It lasts 4 to 6 hours. It takes the edge off, and then you can get the scan without getting a panic attack or getting worried about, the close proximity, because it just takes all of that away. And that's something that, is prescribed often. I used to prescribe it routinely when people have to have coils put in their rectum, 100 cc's of air blown up. I mean, I can't imagine how you can torture somebody any more than, putting a balloon in your rectum this big for an hour. It's unbelievable. And then putting them in a space, and they're like this. I mean, I'm glad that we don't have, the 3T now at least gets rid of the balloon, but the space is still small. So Ativan is a very kind way to have people, take this test, and the doctors certainly can prescribe that for you. So thanks for your attention and your time. We'll sit here for a few more minutes if you have additional questions, but please get yourself something to eat.